Hello, everyone. On behalf of the Leukemia and Lymphoma Society, a warm welcome to all of you. Special thanks to Dr. Andrew J. Cowan for volunteering his time and expertise with us today. Before we begin, Isaac, a myeloma patient, will share some welcoming remarks.
Hi, my name is Isaac, and let me begin by stating emphatically that I have been very lucky in my unluckiness ever since I was diagnosed over 12 years ago with high-risk multiple myeloma. I'm so grateful for all of the amazing scientific advancements in this field, including most recently, the FDA has approved 3 new bispecific drugs and the futuristic CAR T-cell transplants. And for the health insurance I have to cover my treatments, the exceptional health care and support I've received, and let me not forget to mention the LLS with its online group chats, informative webinars, and copay assistance. I've learned to take one day at a time, do what is in front of me today, and remember that people are not statistics. We are all unique individuals. In spite of my high-risk diagnosis, I was fortunate to get 7 years of stringent, complete remission after stem cell transplant 12 years ago, and other treatments following my relapses and remissions. I'm currently regaining my full strength and immunity defenses after a successful CAR T-cell transplant. Truly miraculous. Like most of you, I was understandably scared, confused, and overwhelmed when I was first diagnosed. 90% of my bone marrow was malignant, and I had debilitating back pains. Today, I look towards a promising and hopeful future. The philosophy I embraced at the time and still try to maintain on a day-to-day basis is to partake in and embrace anything and everything I can to improve my status. Integrative oncology. That includes acupuncture, qigong, exercise when I can, mindful meditation, therapy, and the all-important support groups. Nutrition to educate myself as much as possible, and with all this to maintain perspective and a positive attitude. For me, it gives me a sense of some control over my life and well-being, and appreciation of everything around me daily. Although I cannot prove scientifically that this has affected my treatment and outcome, I can say that it has altered my consciousness about my disease and quality of life overall. Rather than feeling victimized and asking, why is this happening to me? It has empowered me. I feel like I have some control and I can do whatever I can to improve the quality of my life in spite of my myeloma. I'm happy to see that some of you embrace this too, as you are here today to learn what we can from this LLS webinar. So welcome, and I leave you with one more bit of advice. My doctor told me he wanted me to walk 10 miles every day. A week went by and I called him and said, Doc, I'm 70 miles from my house. What do I do now?
Well, thank you, Isaac, for not just sharing your story, but continuing to bring us humor and hope through your many years of treatment. And I know that you are an active participant in our myeloma online chat, and you may join him on Mondays on our chats. You may visit lls.org/chat for more information. Now, let us be there for you during this time, and please continue to let us know what you need. We would also like to acknowledge and thank Genentech Inc. and Biogen and Johnson & Johnson for their support of today's program. I am now pleased to introduce Dr. Cowan, an associate professor for the Division of Hematology and Oncology at the University of Washington, as well as an associate professor for the Clinical Research Division at the Fred Hutchinson Cancer Center, and a clinical director of the Hematologic Malignancies Hematology Myeloma Program at UW-Medicine in Seattle, Washington. Dr. Cowan, I am now privileged to turn the program over to you.
Thank you so much for the very nice introduction, and I want to extend a hearty thanks to the LLS for inviting me to talk today. It really is such an honor to talk to all of you folks here. Shown here, you can see my disclosures. Today, this is gonna be kind of a crash bang tour of myeloma. while we're not going to go into in depth on any one topic, I hope we are able to cover many of the most important topics that come up, either for someone who has a new diagnosis of multiple myeloma or someone who's been living with the disease and fighting it for many years. So you can see here some of the topics we're going to cover, talking a little bit about basics about the disease, talking about current treatments for multiple myeloma, some emerging immune therapies, which were only possible, might I add, because of patient participation in clinical trials, managing side effects, quality of life considerations, and then we will wrap it up with some patient and caregiver resources from the LLS. So, and apologies also, I am getting over a cold, so please forgive any throat clearing or nose blowing. I'm pretty sure I can make it through the whole talk though. So, what is multiple myeloma? Multiple myeloma is I think, part of what drew me to this many years ago was it's a unique blood cancer. Unique in how it manifests, unique. It's very different from other solid tumors and other cancers that we're familiar with, like colorectal or breast cancer. The cell that multiple myeloma comes from is a plasma cell. Plasma cells are a very important component of our immune system. They're responsible for producing these proteins called antibodies that help your body fight off infection by binding to bacteria, viruses, and helping your body basically get rid of it. Just like many cancers, we find that multiple myeloma still has some of the features that make it like a plasma cell. And one of them, as we'll talk about in a little bit, is the production of antibodies. That is really one of the major ways that we follow and track the disease is by the M spike. That is a protein that's basically an antibody that's been produced by the plasma cell. So basically what happens with this disease, we get malignant plasma cells infiltrating the bone marrow. Occasionally it can spread outside of the bone marrow into other organs and tissues. Symptoms really depend on tumor burden and complications by plasma cell clones. And what these clones, and what a clone is basically it's a genetically identical cell, and that's one of the hallmarks of cancer. And so we have all these genetically identical cells. Sometimes we have subclones that emerge from the original clone. They produce these antibodies. We call them monoclonal immunoglobulins, or M spikes, cytokines, which are inflammatory proteins, and other factors that interfere with bones and result in myeloma bone disease, which can cause fractures, kidney function from elevated free light chains, sometimes impaired hematopoiesis, which is production of red blood cells, white blood cells, and platelets, other immune mechanisms and other systems. And shown here, you can see on the bottom, this is what a slide of a myeloma biopsy looks like. And those large kind of fried egg cells, that's the myeloma cell. And so that's a plasma cell. And when we see too many of them, that's the hallmark of what a biopsy would look like when someone has this disease. So, I mentioned hematopoiesis a little bit earlier, and I think this slide nicely shows kind of where the plasma cell fits in the scheme of hematopoiesis. What is hematopoiesis? Hematopoiesis is the production of platelets, red blood cells, white blood cells in the immune system from stem cells. And anyone who's had a stem cell transplant knows that stem cells can remake the entire immune system. And so that's shown here. We start out with stem cells up in the top left corner that turn into other cells that produce things like platelets, macrophages, other parts of our immune system, and then produce T cells and B cells, which eventually mature into plasma cells. That's where plasma cells come from. They come from B cells. And so it's sort of considered a B cell malignancy, like lymphoma and chronic lymphocytic leukemia, but it's a very different type. I mentioned the immunoglobulin, and this is really important. Anyone who has multiple myeloma, anyone who's helping take care of someone who has multiple myeloma, really important to sort of understand what this means. An immunoglobulin, again, is also sort of synonymous with an antibody. Antibodies are these proteins. They look like this under a microscope, and they bind to proteins on the surface of virus and bacteria and help your body get rid of it. And so every antibody has an antigen binding site, shown here in the upper right, and a hinge region, and antibodies are made of a light chain and a heavy chain region. Why we care about antibodies is because when there's too many of them that are produced by a clonal plasma cell, we see an M spike. And so this is a test that we get to look for an M spike. Your doctor will commonly be ordering this, if it's applicable to you, to track your myeloma. The test is called the serum protein electrophoresis, or SPEP, and it's usually paired with immunofixation. SPEP tells us how much abnormal protein there is in a blood, in your serum. And so basically what this test is we take a sample of your serum, we put it on a laboratory test called a gel electrophoresis. This separates out proteins by size and charge. And normally we should see this blue pattern here where there's a large spike of albumin. Albumin is a very common protein in our blood. It helps maintain, keep the blood, keep water and fluid inside the blood vessels. But we also see fairly low levels of alpha-1, alpha-2, beta, and gamma, and these are where we see these other antibodies. When we see a spike in the gamma region, that's the M spike. And that's something we see in anybody who has a plasma cell disorder, whether it's smoldering multiple myeloma, whether it's MGUS, or whether it's multiple myeloma. So that's a hallmark feature, and most patients, probably 90% of patients, are going to have a detectable M spike by SPEP. Serum-free light chain, that's another test we commonly get to evaluate multiple myeloma. Serum-free light chains are part of that antibody molecule. They are part of the antigen binding site. They're actually manufactured separately inside the plasma cell and then put together to create the antibody molecule. Serum-free light chains are important for several reasons. One, for some patients, they're going to be the primary way that we track the disease. And there's this test called the serum-free light chain test that your doctor is probably ordering or should be ordering every month. And what that'll tell us is there an elevation in kappa or lambda? And every patient is either going to be an elevated kappa or an elevated lambda. Same goes with the antibodies. There's 5 types of antibodies that people can have. IgG, IgA are the most common. IgM and IgD are slightly less common, and IgE is very rare, if ever reported. So most folks are going to be IgG or IgA, and it's uncommon for that to change, although there are reports of that happening. For the most part, whatever your type was, it's going to be the same throughout your entire disease course. So serum-free light chains are important not only because they can track the disease, but also if serum-free light chains are really elevated, that's what leads to kidney failure. And so when they're above 80 milligram per deciliter or 800 milligram per liter, some labs use, there is a much higher risk of developing renal failure. We know that this myeloma kidney disease comes from these free light chains. How common is multiple myeloma? Well, multiple myeloma is not the most common disease. It's, I think, the second most common blood cancer. It's 1.8% of all cancer cases in the United States. There were an estimated 35,000 cases in 2023. Comprises 2.1% of all cancer deaths. What I think the real important point here is the prevalence. So there's 2 things we look at with epidemiology. One is the incidence, and that's the estimated new cases in 2023. That's the raw incidence. We get an incidence rate by dividing that per the population. And so for multiple myeloma, it's about 7 per 100,000 people in the United States. The highest incidence is in Australia, where I think it's slightly higher than that. And we see much lower incidences in other parts of the world. We don't fully understand why the incidence rate varies between countries, but we know it's around 7 per 100,000 in the United States. But interestingly, we see 170,405 people alive with myeloma in the USA. What does that tell you? It tells you that people are living much longer with the disease. If the incidence and the prevalence rate were about the same, we know that most people don't survive very long. But that's not the case, as you can see clearly here, where the prevalence is probably 5-fold higher than the incidence. So that, I think, is a really nice way to show how much we've seen advances in the diagnosis and treatment of this disease. How does multiple myeloma present? This is a super common question. And I think the challenge of multiple myeloma is that the symptoms of the disease are often just common symptoms in general. If you go to a primary care doctor, one of the most common things they see is bone pain or back pain. And back pain is a common presenting complaint of multiple myeloma. Fatigue. Fatigue is another super common complaint in primary care. And so it's because the symptoms are sort of overlap with common reasons that people see the doctor. Unfortunately, a lot of times it can take a while to get a diagnosis. Sometimes people might get labs checked and they might have an elevated total protein. That's a way that sometimes folks have found out that they have myeloma, because that total protein is elevated because of the M spike. Anemia that's unexplained is another reason that people get diagnosed. Elevated creatinine or kidney dysfunction from the free light chains, the myeloma cast nephropathy, hypercalcemia, and weight loss. But the most common is anemia. Most people with multiple myeloma didn't know that they had, something like MGUS or smoldering, which we know most of the time predisposes people to getting this disease. And so unfortunately, it does sometimes take a while. But I think it just highlights, that we need to improve awareness of the disease amongst primary care practitioners, and to have a low threshold to order an SPEP, which frankly is a very cheap test compared to a lot of tests that we order, and gives a very easy way to start thinking about the disease. What is the diagnosis? How do we make a diagnosis of multiple myeloma? For 10 years now, it's hard to believe it's been 10 years since the most recent diagnostic criteria came out. These have been the diagnostic criteria. So basically, someone has to have a bone marrow biopsy that shows greater than 10% plasma cells, or a biopsy-proven plasmacytoma plus the CRAB criteria. And the CRAB criteria is a mnemonic. It's a mnemonic that doctors use to help remember the symptoms. And that includes hypercalcemia, which is the C, elevated calcium. Renal failure is the R, and that's kidney failure. Anemia, and myeloma bone disease, which are the bone lesions, which are usually, when we look at an X-ray, they're osteolytic bone lesions, which are basically punched out holes in the bones. There are some new additions with 2014, not necessarily new anymore, it's a decade old, but the most new, I suppose, and that's the inclusion of the serum free light chain ratio of involved over uninvolved greater than 100, more than one focal bone lesion on MRI, and greater than 60% clonal cells, plasma cells on a bone marrow examination. And so increasingly, sometimes we have folks who are diagnosed with multiple myeloma based on these biomarker-driven criteria where they don't have any symptoms. And so it can be kind of a disconnect between being told by your doctor, hey, you have a bad cancer, but, hey, doc, I feel fine. And, it's worth knowing why. Why do we include these? It's because these were previously patients who would have been considered to have smoldering MM, meaning asymptomatic myeloma. We don't always treat that. But these patients who had these features had a very high risk of developing active myeloma within the next year. And so because of that, we opted to basically include them as a part of having myeloma, to try to make sure we're getting patients treated before they get hypercalcemia, renal failure, anemia, bone lesions, with the idea that why wait? If we know patients have a biologically high risk of developing the disease, we should try to treat before onset of symptoms. And so that's sort of the philosophy that led to inclusion of these in the diagnostic criteria. So let's shift gears a little bit and talk about treatment. So I'll discuss the data that supports some of these sort of recommendations, but in general, this is how I think about treatment of newly diagnosed multiple myeloma in 2024. So for folks who are transplant eligible for an autologous stem cell transplant, we typically would recommend starting with a 4-drug combination, most commonly daratumumab, lenalidomide, bortezomib, and dexamethasone, or dara-RVD. Dara-KRD, which substitutes the carfilzomib for bortezomib, could be considered in some patients, especially if someone has neuropathy and we want to avoid making that worse with Velcade. But it's not clear that one is better than another necessarily. 3-drug combinations might be okay, but I think for the most part, anyone who's transplant eligible, dara-RVD should be considered and offered based on some of the studies I'm about to show you. Stem cell transplant is the next box here. And stem cell transplant is still something that we very much think is part of the treatment of newly diagnosed multiple myeloma. Transplant is basically, the key part of the transplant is not actually the transplant itself, but rather it's administration of high-dose chemotherapy, a drug called melphalan, to further improve the depth of response in people who have gotten upfront treatment with their RVD. Transplant is something you want to have a pretty in-depth conversation with your doctor about and with the transplant team to understand risks and benefits and really to help you make an informed decision. Because, transplant ultimately is the decision to pursue transplant is one that you should make with your doctor. You should not feel forced to get a transplant. But we still think transplant is a very important part of treatment, as I'll show based on the results of a large study that was done. For maintenance, maintenance just refers to a lower dose of the drug that we were getting when we started, but the goal is to try to keep the disease at bay. Numerous studies have shown that maintenance is beneficial at improving survival. And so I recommend maintenance to everybody after a stem cell transplant. We didn't really talk about this because there's so much to cover, but there's also one of the things we commonly look at with multiple myeloma, which is alluded to here in the slide, is whether you're standard or high risk. Just so you know, the high risk markers are things like deletion 17p, the translocation between chromosomes 4 and 14, and translocation 14-16. Those are the three that are most commonly accepted. There are others like a 1q amplification, translocation 14-16, and just know that those are commonly considered high-risk features. There's other features of the disease that can be considered high risk, like having an anaplastic morphology or having plasma cell leukemia. Anyone who kind of falls into those would be considered high risk. For patients who are high risk, we commonly would recommend 2 drugs for maintenance, usually a proteasome inhibitor, that's what PI is, and that includes drugs like Velcade or bortezomib and carfilzomib, or CD38 plus an IMiD. Standard risk, we typically would consider lenalidomide, although with Perseus, I think using daratumumab and lenalidomide is very reasonable, and we'll cover that data in a second. For folks who are not transplant eligible, we typically would start with daratumumab, lenalidomide, and dexamethasone, or the RVD regimen, which is lenalidomide, bortezomib, and dexamethasone, followed by maintenance. And then supportive care is really important, and we'll talk about that a little bit later. Supportive care starts at the time of diagnosis and continues throughout. What is supportive care? Supportive care is paying attention to all the other things besides treatment. And so that includes aspects such as preventing infections. We know that myeloma treatment causes an increased risk of infections, particularly shingles, and so often we'll give, almost always, anyone getting a CD38 antibody or a proteasome inhibitor should get an antiviral for prevention of shingles. Bone health, paying attention to bone health. We know that drugs such as bisphosphonates and denosumab can reduce the risk of myeloma-related bone fractures or bone events. And so this should be something you discuss with your doctor. Not only that, immunomodulatory drugs such as Revlimid and pomalidomide and others have a risk of causing blood clots. And so we commonly recommend drugs to prevent those, such as aspirin or maybe a direct oral anticoagulant, for example, like Eliquis. Finally, there's the quality of life aspects, and many of these drugs can cause neuropathy, bortezomib being the most common one. We'll talk about that later. But also managing side effects like fatigue, gastrointestinal side effects, risk of falls, and loss of strength. And we'll talk about that a little bit later. But supportive care is super important. And if we don't manage supportive care correctly, we don't get as much benefit from these treatments. These treatments are amazing. They've prolonged people's lives, but we have to pay attention to quality of life and making sure that the rest of a patient's health is supported throughout getting myeloma therapy. So let's dive into a little bit of the data. So I'm going to present a couple of studies here that support the use of daratumumab and RVD, just so everyone can understand why this is a new standard of care. The first study that showed this was beneficial was the Griffin study. which was a randomized phase 2 study comparing the RVD regimen to Dara-RVD with transplant and maintenance. This study showed an improvement in rates of stringent complete response. What does that mean? It means there's no evidence of myeloma in the bone marrow, in the urine, in the blood, either by SPEP or free light chain. So basically, as close as we can get to what the solid tumor docs sometimes like to say, NED, no evidence of disease. And so this met its endpoint. There was a higher rate of stringent CRs in patients who got Dara-RVD with transplant and maintenance compared to RVD, 42 versus 32%, and also a higher response rate in general. 99% of patients had any response, meaning reduction in the monoclonal protein or free light chains, compared to only 91% of patients who got RVD. So I think that's a pretty dramatic improvement, especially if you consider the 9% of patients or so who don't respond to RVD. We know that those patients don't do quite as well. So we're really moving the needle quite a bit with their RVD. We also saw with Griffin that the time to minimal residual disease negativity was improved. So you're asking yourself, what the heck is MRD, for some of you who may not have heard this term before? A lot of you probably have. MRD is referring to tests that can detect disease at a much lower threshold than conventional tests. The most common test is the clonoSEQ test. This is a DNA-based test that detects myeloma in the bone marrow. And basically, this can detect disease that we can't see with standard tests, like flow cytometry of the bone marrow. And so what we've seen with studies is that if you can get to a state where there's absence of MRD by this next generation test, this next generation sequencing, we know in general that patients tend to have longer remissions. They stay in remission longer. And we know that that always typically equates to having better survival. So MRD is increasingly becoming something that we are paying attention to. And this study showed that patients achieved MRD negativity much quicker with Dara-RVD compared to RVD. And more patients achieved MRD negativity, as you can see here on this graph, which shows the percentage of patients achieving MRD negativity with either RVD or Dara-RVD. The other thing that oncologists typically look at with a treatment is a measurement called progression-free survival, or PFS. So what the heck is that? PFS is a measurement where an event happens if someone either passes away or the disease progresses. And so it's a rough way to kind of look at how long is this treatment keeping people in remission. So when we see improved PFS, what that means is, in general, people are living longer without the disease coming back, which we think is really important with myeloma because of how bad some of these disease complications can be. In Griffin, it took a few years, but we saw an improved PFS after 3 years and 4 years in patients who got Dara-RVD compared to RVD. So great. We have this smaller phase 2 study. Next, there's this Perseus study, which some of you might have heard of. And this was a larger study. It was done globally. So they had sites in Europe and Australia and Asia. And this study was basically very similar design to Griffin, except for they had a lot more patients, and it was a global study. And so patients got either RVD or Dara-RVD. They had to be transplant eligible, 18 to 70 years, and have good performance status. And everyone either went Dara-RVD or RVD, followed by transplant, followed by consolidation, and then followed by maintenance with either lenalidomide or daratumumab and lenalidomide. One difference between Perseus and Griffin is that Perseus allowed folks who achieved MRD negativity to stop daratumumab after 12 months of sustained MRD negativity. And so that's a little bit different. The outcomes are shown here. And again, these are one of these, we call these Kaplan-Meier curves that I've shown you so far that show PFS. And so the yellow on the top is the Dara-RVD arm. The blue on the bottom is the RVD arm. And I think it's pretty clear that the folks who got Dara-RVD fared much better. There was a dramatic improvement in PFS that was statistically significant. And this was seen across almost all subgroups. I think what's really striking here is if you follow folks out 48 months, which is this tick just 2 to the right here, to the left, sorry, of the graph, we're seeing like almost, just almost 90% of patients still without progression at 4 years, which is pretty remarkable. And you compare that to RVD, which is only 70% or so. So this is, I think, really dramatic and confirms really what we saw with Griffin. And we see it across all subgroups, even in the high-risk subgroup. Similarly, responses are better in patients who got DAR-RVD, which should be no surprise based on the Griffin study. And we see here 87% of patients had a CR, a complete response or better, compared to 70% of patients who got RVD, who got a CR, again, seen across most of the subgroups. And this again shows these responses and also shows the rates of MRD negativity. And note at the bottom here, I hope you can all read this, the very, I would argue, high rates of MRD negativity amongst the patients who received DAR-RVD, 65% versus 32%, with 65% of patients achieving sustained MRD negativity for more than 12 months compared to 30% of patients who got RVD. So I think these data are so clear that this is a vastly superior therapy. So you're asking yourself, well, gosh, Dr. Cowan's saying that this is better, but what about the side effects? We're adding another drug. Does this make my quality of life worse? Well, I think that's a very fair question anytime we're like adding therapies. What is this doing to my quality of life? So pulling from Perseus, what are the common adverse events? So neutropenia is, I just pulled these out of things that I thought were important. There's obviously a lot of side effects that you could read through with your doctor, and you should. But neutropenia was slightly more common with DAR-RVD, seen at 70% versus 58%. With grade 3 or 4 neutropenia seen in 29% versus 70%. So you're asking yourself, what do these gradings mean? Grade 3 or 4 just refers to how low the neutrophils went. And neutrophils are these fighter white blood cells that your doctor should be checking when you're getting treatment. If they're super low, it predisposes you to specific infections, particularly bacterial infections. And so we get worried when neutrophils are low, and we often will give growth factors or give antibiotics so that people don't get these bad infections. Thrombocytopenia or low platelets, also really common, more common with DAR-RVD. Peripheral neuropathy, fortunately, was similar between the two groups. So daratumumab should not worsen neuropathy, and that's what we would have expected based on the side effects of this drug. 50% of patients had any grade neuropathy. Fortunately, very few patients had grade 3 or 4 neuropathy, which would be neuropathy that impacts quality of life or ability to do ADLs. Infections were also more common with DAR-RVD, which is not surprising because daratumumab is a monoclonal antibody that suppresses the immune system. So it's not surprising to see this. And so it's just important. I think it highlights the importance of being vigilant about infections when we're treating people with this regimen. So to summarize, we now have seen 2 trials that have shown a benefit for daratumumab and RVD. And so I think this confirms that this should be really a standard of care for anyone with newly diagnosed multiple myeloma who is transplant eligible. There are other studies, of course, that have shown benefits of a quad regimen, but I think these are sort of the most clinically applicable trials in the United States. And so that's why I chose to highlight them. And the other point I would make is that I think daratumumab and lenalidomide maintenance is a reasonable option based on Perseus, although there is still some, I guess, debate about this in the field. How do we give this a Fred Hutch? And this is just an example. I think what I wanted to highlight here is that often in these studies, bortezomib is given twice a week. We feel pretty strongly that weekly bortezomib should be preferred. There's lesser risk of neuropathy. It's more convenient. Patients aren't spending as much time coming in to get infusions. So hopefully most of you all, if you've gotten this or are getting this weekly. If you're getting it twice a week, I think probably try to talk to your doctor and see if they're willing to change. We don't think that this impacts like how well the treatment works. We try to make sure we use DEX appropriately, but we also stop it if people are having side effects. And so we commonly will de-escalate DEX in our practice. After transplant, we generally don't give consolidation. For a long time, we were giving just lenalidomide maintenance, but I think it's very reasonable to give daratumumab and lenalidomide maintenance. And really, nobody should be getting DAX during maintenance. So please try to get off the DAX during maintenance if you're not already, because that can really lead to a ton of consequences like worsening diabetic glycemic control, proximal muscle weakness, and visually significant cataracts. So what about transplant? So I've been talking a lot about transplant, and I think the data are still really clear that transplant improves progression-free survival for newly diagnosed myeloma. The most recent study we have that demonstrates this is the study called the Determination Study, which compared RVD transplant and lenalidomide maintenance to RVD and lenalidomide maintenance, and it showed an improvement in progression-free survival with transplantation by about 19 months. And so you can see these curves here. The red curve is the transplant curve. The RVD curve is blue. We assume that this benefit would be seen with our RVD as well, although that study is probably not ever going to be done. And so I think, I think this RVD data is good enough to say that transplant still plays an important role and should be considered in anyone who's transplant eligible. What about folks who decide not to undergo transplant? And this data, I have to admit, this is a little bit, this is subject to change. Some of you might have heard that the study called the IMROZ study, which is a study of quad therapy for folks who are not transplant eligible. There was a press release recently that was a positive result. We don't yet have a paper or a presentation, but I think, pending those results, some of this could change. But as of today, the MAIA trial and the SWOG S077 trial, the most informative for folks who are transplant eligible. MAIA study compared daratumumab, lenalidomide, dexamethasone to lenalidomide, dexamethasone in transplant ineligible multiple myeloma. And basically, this study showed I think these results are pretty amazing. They did a long-term follow-up of the data here and showed that the 60-month progression-free survival rate was 52%. So that means if you follow folks out 5 years, half will have relapsed and half will have not. So that's actually not too dissimilar from Determination, RVD transplant maintenance, which showed a median PFS of 67 months. So that's pretty remarkable. And this is a population of patients much older, much more frail, who achieve really excellent outcomes just with daratumumab, lenalidomide, dexamethasone. The other regimen that you can consider would be RVD. I personally feel like the MAIA data are more practical in sort of a more older, frail population because there's no risk of neuropathy with daratumumab. And so I think that's really impactful to have this really great regimen that does not cause neuropathy available to us. And I think we do have to be mindful of infections for sure, but these are really powerful data. The RVD regimen is very reasonable too, though. We don't know for sure which one is better, but I think RVD is reasonable. Want to make sure we don't continue people on bortezomib forever, though, because of the neuropathy risk. And one situation where we might consider RVD over DARA-RD would be someone with high-risk genetic chromosomal features, where often we really still think it's important to include a proteasome inhibitor. And so that might be one situation that might lead your doctor to recommend RVD over DARA-RD. What about reducing steroids? And this is also really important in sort of the more frail population. There was actually a study in France that looked at trying to minimize or lessen the use of steroids for newly diagnosed multiple myeloma. And this is actually a study that was done that was basically a DEX-free regimen with daratumumab and lenalidomide compared to lenalidomide plus low-dose DEX. And they showed pretty interesting results. At month 12, the folks who got daratumumab and lenalidomide and no DEX had a VGPR or better rate of 71%, which is pretty impactful, compared to the patients who got len plus low-dose DEX with only a VGPR better rate of 55%. So I think these data support that it is okay to titrate down dexamethasone, especially if it's causing side effects, especially if it's making it difficult to sleep, especially if it's causing glycemic control issues. These are all very valid reasons to try to lessen the DEX exposure after you've been on it for a while. I'm not talking right at the start. I'm talking you've been on this treatment for a while. It's okay to reduce the DEX or even stop it. So what about shifting gears a little bit? Let's talk a little bit about relapsed multiple myeloma. So relapsed multiple myeloma, unfortunately, even with all these treatments that I've just outlined that are so effective, so good at getting people to remission, we know that the disease comes back. And this can take months, it can take years, hopefully years for most people getting modern therapy. But this is kind of an outline of how I think of what to do when people relapse. So for people who've had, when I talk about a line of therapy, by the way, you'll see that here, that just means a treatment. So a cocktail of drugs. So whether that's sterile RVD and transplant, that would be one line of therapy. Carfilzomib, pomalidomide, dexamethasone, that would be considered a line of therapy. So any cocktail where you're changing it up to try to treat the disease coming back, that would be a line of therapy. And this comes up with CAR T because right now, CAR T can't be given and bispecifics can't be given unless people have had 4 lines of therapy, which is what's on label, and hopefully that will change soon with the FDA reviewing data from CAR-2 and 4 and KarMMa-3, which we'll talk about a little bit. But basically, for folks who have 1 to 3 prior lines of therapy, we would typically consider a CD38 monoclonal antibody with either pomalidomide or carfilzomib. Both would be very reasonable. There's a couple studies, Candor and Ikema, which looked at isatuximab, which is CD38 antibody with carfilzomib, or daratumumab with carfilzomib. Both are very effective combinations in that sort of 1 to 3 prior line of therapy. Other drugs that you can get in this space would be selinexor, bortezomib, and dexamethasone. Selinexor is a selective inhibitor of nuclear export. Elotuzumab, pomalidomide, and dexamethasone. These are all just options that you could consider and talk over with your doctor. But ideally at this point, I should have mentioned this earlier, it's a good idea to see someone who focuses in myeloma, even when you get diagnosed, even with your community doc. See them once just so they know who you are, just so you kind of get plugged into the system. And it can be really helpful just as you go on through your, having myeloma, which is like a chronic condition, making sure you check in when you need a new treatment. Is this really still the state of the art? Am I eligible for a clinical trial? And I think one important point that should be at all of these 1 to 3 prior, any of these kind of categories, consider a clinical trial. Clinical trials are so vital to advancing our knowledge and to getting drugs approved that I think it's really important to consider them. I mean, this could be a whole talk in and of itself on why to consider clinical trials. But one important one is that, none of these drugs we would have unless folks had participated in clinical trials. So they're always optional, but just remember why they're important. And always, ask your doctor when you're needing a new line of treatment, am I eligible for a study? Can I see a myeloma specialist to get a second opinion? And the answer to both should always be yes, but ultimately you get to choose. And you and your physician get to choose how you want to treat. For folks who've had progressive disease with more than 4 lines of therapy, that's where we start thinking right now about BCMA CAR T cells, BCMA bispecifics, or GPRC5D bispecifics. And then for post-BCMA relapse, really the only drug that we kind of comes to mind immediately would be talquetamab, which is recently approved GPRC5D bispecific antibody, or clinical trials, which seems obvious. So let's talk a little bit about CAR T cell therapy, since that I think is of high interest at this point, especially in the 1 to 4 prior lines of therapy with the FDA reviewing some data from these studies. CAR T cell therapy is an immune-based therapy, and it really marries kind of advances in, genetic engineering, understanding of immunology, understanding of disease biology. And so it's kind of an amazing therapy. Basically what we do is we take your T cells out of your body. We use a virus to genetically modify the T cells so that they now can target the cancer, and then we give them back to patients. And that process is shown here. CAR T cells have to be manufactured, which is part of why there's been, some resource limitations with respect to how many patients can get it. There are other reasons for that too, but one of them is just this manufacturing, which is, has been scaled up, but it's still a bit of a challenge. So when we manufacture CAR T cells, we start with leukapheresis, we select the T cells, and then we activate them and transduce them with this virus, and then we expand them and harvest and formulate the final product. That's the process of how we create CAR T cells. And this can take several weeks, depending on the exact product and the specifications. What are some general toxicities from CAR T-cell therapy? These are listed here. So cytokine release syndrome is one. This is that syndrome that is characterized by fever, low blood pressure, sometimes low oxygen. And this is pretty common in patients getting CAR T, or I should also mention these are toxicities that can also be seen with bispecifics. So there's some overlap here. Immune effector cell neurologic syndrome or neurotoxicity is sometimes overlaps with cytokine release syndrome, sometimes not. Typically, patients can present with sort of handwriting abnormalities or confusion or lethargy. Another thing that can happen after CAR T-cell therapy, these prolonged low blood counts. We call this ICAT, or prolonged cytopenias. B-cell aplasia or hypogammaglobulinemia basically refers to reduced production of antibodies, and this can lead to an increased risk of infection. Sometimes doctors will give a product called IVIG to help deal with this. And then secondary cancers. And this is a hot point, after many of you have probably seen press releases and from the FDA that they're concerned about this. And, basically it's this idea that when we're doing any kind of genetic engineering, and this is borne out not only by CAR T cells, but, by other studies that have, looked at genetic manipulation, there's a theoretical risk that we could perhaps turn on some gene that could turn a cell cancerous. Now, to date, there hasn't been we've treated many patients with CAR T cells who have lymphoma, and now many patients with myeloma, and there have been some potential cases that could qualify as secondary cancers caused by this mechanism. Frankly, this is something we've always counseled patients could be a risk, or at least I have. And it's something that the fact that we found it means we're looking for it. And that gives me confidence in the systems that we have, that we're able to detect rare events and get on top of them. And so I think this risk, is not only theoretical, it may be real. If it is real, I think that it seems clear to me also that the benefit of the treatment in terms of treating the myeloma probably far outweighs the risks of these. It's something you definitely want to talk to your doctor about. I think you want to kind of get all the information about it. But it's clear that, and we have this happens with other treatments, stem cell transplant. There's a risk of secondary cancers, but we know that patients do better long-term with transplant despite these risks. And the same goes with lenalidomide, which has a risk of causing secondary cancers, but has also been shown to improve survival. So we have to remember, what is the thing we know we have to deal with? And that's myeloma. And then there's always there's uncertain things like toxicities, and secondary cancers fall into that. And so I think you have to keep that perspective of what the known thing that we're dealing with and how to best treat that, and that the benefits of that outweigh these risks. But it's important for you to be informed about this. And I think ultimately it's only a decision that you can make in conjunction with your doctor. So we talked a little bit about this, and basically cytokine release syndrome is a pro-inflammatory syndrome caused by excessive immune activation, and the hallmark is fever, hypotension, hypoxia. This kind of shows how this happens. Basically, you can think of CRS kind of like, what's kind of happening is when you, let's say, for example, what do T cells normally do? When you get an infection, they recognize that there's a virus, and they produce these proteins called cytokines. The cytokines cause your immune system to say, hey, let's wake up. We got an invader here. Let's go into attack mode. And so, largely, why do you feel sick when you get influenza? I mean, it's not totally because of this, but a lot of it is because of what happens to the immune system. And the activation of the immune system causes things like fever, can sometimes cause low blood pressure, can sometimes make your blood pressure drop. And so that's basically what's happening here with CAR T cells. We take our T cells, which normally are supposed to be out there fighting infections, and we're now telling them to target cancer cells. And that results in, a syndrome very similar to what you might get, say, with a viral infection. Down here you see more severe CRS. That's less common, but it can happen. And it's always important to review these risks with your doctor when you're thinking about getting CAR T cells, and what the risks of these treatment-related side effects are, and how they could affect things like, having a bad outcome. Fortunately, it is rare, but they can happen. The neurotoxicity, which is now known as ICANS, Can happen with or without CRS. It ranges from sort of mild confusion or lethargy to more severe states like global encephalopathy. Frankly, the latter is quite rare. Important to know this has resulted in deaths of some patients receiving CAR T-cell therapy. With early treatment and with early recognition, that has become less common, but it's still something to be aware of and something for caregivers to be aware of too, because it can be really scary when you see your loved one very confused or lethargic, and it's important to know that this risk is there. And we treat this with dexamethasone. I should mention also that we treat cytokine release syndrome, the one we talked about earlier, with tocilizumab, which is an IL-6 antibody, that's a cytokine, and dexamethasone. So what are the data for CAR T-cell and multiple myeloma? So there's 2 approved CAR T-cell products for multiple myeloma. There's Abecma and Carvykti. Ide-cel or Abecma was the first one that was approved in 2020 based off of the KarMMa-2 and KarMMa-1 studies. And so they studied this in patients with 2 to 4 lines of therapy who are triple class exposed and looked at either Ide-cel or a standard of care therapy. And crossover was allowed. Primary endpoint of the study was progression-free survival, and they indeed showed that this improved progression-free survival over standard regimens. When they looked at overall survival, the 2 groups were actually quite similar, which initially, one was a little bit concerning until you remember that they allowed crossover. So if patients were on standard of care arm, they could get BCMA CAR T cells later. And so I think it's difficult, if you can assume that most patients would probably get that, it's going to make survival analysis challenging. When they did a pre-specified sensitivity analysis just for crossover, they showed that there was a trend towards benefit of receipt of idacaptogene or Abecma, and also a trend of OS benefit amongst treated patients. So these were the data that were reviewed by the FDA, what we call the Oncologic Drugs Advisory Committee, or ODAC, which basically advises the FDA on what to do when there's a challenging decision about approving a drug. That happened a few weeks ago, and hopefully we'll hear about whether this new indication for Abecma gets approved very soon. The other CAR T that's out there is Carvykti, or ciltacabtagene autoleucel, and this is another BCMA-targeted CAR T. It was studied in the CARTITUDE-1 study, whose design is shown here. CARTITUDE-1 showed pretty impressive results, specifically with respect to PFS and rates of MRD negativity. And this was a group of patients who were very heavily pretreated. They'd had a lot of different therapies, and they had pretty remarkable durable remissions with Carvykti, with a median PFS of almost 35 months and a 12-month sustained MRD negativity at 30 months of 75%. Carvykti was studied in CARTITUDE-4, which is kind of a similar study design to KarMMa-3, except for they allowed 1 to prior lines of therapy, and patients had to be len refractory. So it's a little bit earlier than Abecma, KarMMa-3 rather. This study also showed pretty, kind of in line with CARTITUDE-1, pretty dramatic improvement in PFS compared to standard of care regimens, with a median progression-free survival that was not reached for Carvykti compared to a median PFS of 11.8 months. So I am optimistic, again, that these data will lead to approval in these settings, but we'll see. I think we don't know yet. What about bispecific antibodies? So bispecific antibodies are drugs that basically kind of very similar to CAR T-cell therapy. We use the immune system to target the cancer, except for we have a protein that's been engineered to take the T-cells and bring them to the cancer cells. There are several bispecifics that are approved. The ones that are approved are teclistamab, elranatamab, and talquetamab. There are others on this list here that are in development and may be approved in the coming years. So it's nice to have lots of options in the pipeline. These drugs, compared to CAR T-cell, maybe the response rates are not quite as high, but when people do respond, the responses tend to be quite durable or long-lasting with teclistamab and elranatamab. They also have risks of cytokine release syndrome, just like CAR T, perhaps slightly higher risk of infections, severe infections compared to CAR T, and there is some hospitalization required for these drugs when they're given. which I think folks are looking at trying to get around by administering outpatient, but the studies were all done with hospitalization required. Talquetamab in particular has a particular set of side effects, including skin toxicity with rash and nail loss, and also loss of taste that I think are a little bit of a challenge to manage at the moment. And so just really know that there's several of these drugs that are available, and there are others that are in the pipeline. So let's kind of switch gears a little bit in the interest of time and just talk a little bit about quality of life considerations and managing side effects. So treatment-related side effects are a common conversation that I have with folks when talking about myeloma treatment. And the ones that come up most commonly are peripheral neuropathy, lenalidomide side effects, and fatigue. Mobility and strength is another one that comes up a lot. Doctor, I want to I want to go downhill skiing. Can I do that? I want to go back to the gym and lift weights. Can I do that safely? And so this addresses this issue of loss of muscle strength. The medical term for that is sarcopenia. And then finally, a little bit about diet and myeloma. So what is peripheral neuropathy? Peripheral neuropathy just refers to a general dysfunction of nerves. And there's three components of our nervous system. There's autonomic, there's sensory, there's motor, and it can affect any of those. So if you have a sensory neuropathy, people can have pain, they can have tingling, coldness, burning, and numbness. Motor neuropathy can result in weakness and atrophy of muscles. Autonomic neuropathy can result in lightheadedness when standing up, dry mouth, diarrhea, or erectile dysfunction. So obviously, even mild neuropathy can really impact somebody's quality of life. Now, you saw earlier, I reported on rates of grade 3 or 4 neuropathy with some of these regimens, and they're only like 3 to 4%. But really, I want to make it clear that any neuropathy can be really, really, I mean, I'm preaching to the choir here, any neuropathy can be really a bad outcome. Like, what are some general advice for neuropathy? So these are just some tips I've given to folks, and this comes originally from a great piece of advice. Some documents I received from Janice Weissman, who was an amyloid specialist at BU, who unfortunately passed away a few years ago. But she had this whole document on healthy nerves, and so that's where I'm getting some of this from. So decrease alcohol intake. Alcohol has direct toxicity to nerves. So, if you are drinking more than a few drinks per night, consider cutting down or consider cutting out entirely. Stop smoking. If you are a smoker, there's numerous reasons to quit. But if you are a smoker and have neuropathy, there's an added reason, because smoking causes constriction of blood vessels that nourish your nerves. Eat a diet rich in fruits, vegetables, especially dark green leafy vegetables that contain B vitamins. And we'll come back to this later when we talk about diet. Make sure to discuss first with your physician if you're on any kind of blood thinner like warfarin, because that can interfere with that. And then really, very simply, muscles use nerves to stay healthy. So use your muscles, stay active. I like to tell people that walking is one of the most underrated activities. And I heard the comment at the beginning about how the patient's physician recommended walking 10 miles a day. I typically start with lower goals, maybe like 30 minutes a day of walking. It doesn't have to be fast. You want to talk with your doctor first about this and make sure, there's no safety considerations like risk of falls. But doing some walking is really beneficial. Not only you're getting outside, you're getting sunlight, but you're also using your muscles, and you're putting weight on your bones, and all that helps keep you strong. So walk every day. I mean, that's really a very simple thing that you can do. Are there interventions for neuropathy? Yes. So there's this vitamin regimen that was originally sort of, I think, popularized by Dana-Farber, where folks take multi-complex B vitamins, and I think that's reasonable. The only caveat I would have to that is to say, try to be really careful with B6. Don't take more than 150 milligrams of B6 per day, because that actually can cause neuropathy if you take too much B6. So really be careful with the B6, especially if you're taking one that's got multiple in it. Try to look at the label and be like, hey, how much B6 is in this? And if it's more than what I listed here, I'd probably avoid it. Cramping, stretching of calf muscles can help. For pain and burning, there are some medications. I'll always discuss these with your physician, of course. Gabapentin can cause some drowsiness and fatigue. It can be really helpful, though, for some folks with neuropathy. Pregabalin has similar side effects, or Lyrica, to gabapentin. Duloxetine is another one that you could consider. And then tricyclic antidepressants have also been used. What about fatigue in multiple myeloma? So fatigue is super common in multiple myeloma. It's one of the most common things I talk about with people, to sort of not only just fatigue, but also kind of the brain fog. And, a lot of times this is related to treatment. Sometimes it could be from the disease. Sometimes it could be from pain medications. Sometimes it could be from chronic pain, but it's all kind of intertwined with myeloma. So it's hard to separate. Looking at the studies, grade 3 or higher fatigue and determination, that was the transplant study, 6%. So that may not seem like a lot, but we're talking about fatigue that's so severe, it's impairing people's ability to do activities of daily living. So that's pretty significant. Perseus, any grade fatigue, 24%. There's unfortunately no great intervention for fatigue. I think that exercise, walking is really important for trying to combat the fatigue. Dose reductions of treatment can also be helpful in some situations, but it doesn't always fix it. So bring up fatigue. Don't be shy. Don't feel like you have to suffer through fatigue just because, you're getting cancer treatment. Talk about it. The goal should be to try to maintain some level of functioning despite being on cancer treatment for myeloma. What about lenalidomide toxicity? This comes up a lot. So the GI side effects are really common with lenalidomide, and they include diarrhea, cramping, sometimes constipation. For the diarrhea, anecdotally, and I have no connection to this company, there's this product called Heather's Tummy Fiber that apparently our dietitians here, Fred Hutch, think is helpful, so you could consider that. Cholesterol is a bile acid sequestrant. It can be really helpful for managing that diarrhea. Discuss it with your physician. It can impair absorption of other medications. For the neutropenia, where we have the low fight or white blood cells, often we use growth factor like G-CSF or Neupogen to manage that, or dose reductions. For fatigue, dose reductions can be used. Also consider discussing with your doctor whether you could change the treatment schedule or the frequency. And then for blood clot prevention, consider everyone who's on Revlimid or pomalidomide should be on antithrombotic therapy, aspirin, apixaban, or something similar. What about mobility and strength? So we talked a little bit about this idea of sarcopenia. What is sarcopenia? Sarcopenia just refers to decreased muscle mass. And so there's lots of risk factors for this. And I hope to explain to you why I think this is something we need to be looking at. But basically, chronic inflammation, mitochondrial damage, hormone disorders, muscle degeneration are intrinsic risk factors. Extrinsic risk factors include physical activity, sedentary lifestyle, obesity, and other factors. And so unfortunately, with multiple myeloma, a lot of these factors may be present in folks who are getting treated, and this can lead to sarcopenia. Indeed, we've seen in studies that this is pretty common. In a single-center study of patients who underwent transplant, sarcopenia was present in 50% of patients and was associated with cardiovascular events. In another study, sarcopenia had a negative prognostic impact. So it was associated with worse outcomes, independent of other known high-risk factors. It's also been shown to be associated with risk of developing neurotoxicity in a study that was done of folks who were getting CAR T-cell therapy. And in a study of 341 patients, low muscle rate density was associated with higher disease stage. So it seems it's either something that goes along with some of these factors or it's an independent risk factor. So we know that it's bad. What do we do about it? So this comes up a lot. Doctor, my prior doctor told me I couldn't do any exercise because I could break a bone. So this gets to a common concern with multiple myeloma, which is, we know that multiple myeloma patients are predisposed to having fractures. Is it safe to exercise? Is it safe to do resistance training? So I think it's great. One of the myeloma specialists over in Buffalo, New York, did a study. Dr. Hillengast did a study of supervised resistance training in a pilot study, and so important that this was supervised. So if you hear this, it doesn't mean I can go to the gym and start doing the squat rack again or doing bench press. I think if you want to do a resistance training program, talk to your doctor and try to find a way that you can get a supervised resistance or a training program. But what they showed in this resistance training program was an improvement in 6-minute walk time and an improvement in strength training. So this intervention seemed to be beneficial, this walking and resistance training cohort. And importantly, there was no grade 3 or higher adverse events and no fractures. So I think that this should be reassuring for those who have asked about this, that we can do this, it can be done safely, but it should be done in a supervised, monitored setting. What about the impact of diet? And this comes up a lot. Doctor, I have smoldering myeloma or I have active myeloma. Is there anything I should eat to help reduce my risk of progression or to treat the disease? The long story short is, yes, your diet probably is beneficial. No, is it going to change the trajectory dramatically? It's unclear. More research needs to be done, but this is from a very nice review by Dr. Urvi Shah, who is kind of a leading expert in the field of diet and myeloma. And basically, this is a nice summary of some of the evidence to date, which is all sort of epidemiologic. There is some more translational basic research on the gut microbiome, or the bacteria that are part of our gut that are, have a close interplay with our immune system. But basically, it kind of comes back to what I was talking about with neuropathy. And this would be advice I would give anyone. It's beneficial. You want to have a good diet, and that includes eating whole fruits and vegetables, whole grains and fiber, beans and legumes, avoiding processed foods, avoiding things like high fructose corn syrup, all that stuff that we know already is bad for our health. There's an even added importance to try to have a good diet when you have multiple myeloma. You want to keep your body as strong as you can. Hopefully we'll have more research in this area in the future. And I'm pleased to see that there's such an interest in this going ahead. So to summarize, we're seeing kind of unprecedented improvements in survival for folks with newly diagnosed multiple myeloma. Now with our quad regimens, which are very effective, we're also seeing gains in relapsed multiple myeloma. Again, not to kind of, harp on this again, but a lot of this is because of these clinical trials. And so clinical trials are so vital to advancing the field. So please think about trials when, you're going through treatment. Talk to your doctor about them. They're always optional, but they're worth considering, because sometimes you could get access to a treatment that you otherwise would not be able to access. It's new and promising. However, quality of life on treatment is still a major issue. Neuropathy, fatigue, GI issues, strength and energy are all aspects of life that I think we could do a better job of addressing. It's nice to see that we're starting to, and this is a major interest of mine as well. And I think future research needs to focus not just on improving survival and finding a cure, but also on making life more manageable when getting these treatments, making it so that people can continue living like a full life, and not dealing with treatment side effects all the time. So with that, I will conclude. And I think we have a little bit of time for questions. Sorry for going over a little bit, but there was a lot to cover.
Well, thank you so much, Dr. Cowan, for volunteering your time with us today to discuss multiple myeloma and the advances in treatment. As you mentioned, it is now time for our question and answer portion of our program. For everyone's benefit, please keep your questions general without many personal details, so Dr. Cowan can provide answers that are general in nature. Thank you. Doctor, our first question comes from Danielle. Danielle has smoldering multiple myeloma. She says, I'm borderline on high risk. Anything I can do to slow the progression, and what increases risk? Anything to avoid?
That's a great question. So, for smoldering multiple myeloma, really the only proven interventions to delay onset of multiple myeloma would be, there was a large study that compared lenalidomide to placebo. It was called the ECOG study. And it showed that lenalidomide could reduce the risk of progression to myeloma. That's a therapeutic intervention. Obviously, lenalidomide has a ton of side effects. And so many people would, are not, thrilled about that option. There are trials out there, many trials looking at early treatment of smoldering MM. So you may want to look at one of those. In terms of sort of lifestyle modifications, there's nothing proven, unfortunately. I would say that in general, my advice would be to try to maintain a healthy weight, meaning, ideally a BMI that's close to 25. Try to make sure that you're in good health in general, eating a healthy diet. Try to make sure other health problems like diabetes and such are controlled. I mean, I think you really want to optimize your health. With smoldering not every, it's very variable in terms of how long it takes for someone to get myeloma, but you really want to make sure that your health is as good as possible if that did happen. I mean, that's one way to think about it. Could making those lifestyle modifications change the trajectory? I mean, we don't have data that says it could, but we don't have data that says it couldn't. So I think this is something where there's really no downside to changing your health. And so I don't know if that's helpful or not, but I think, there's getting a diagnosis like this is absolutely reason to try to optimize your health for sure.
Thank you. And we'll take the next question from our telephone audience, please.
Our next call is from Laura from Pennsylvania. Please state your question. Your line is now live.
I noticed, I just took the Tecvayli, and that really didn't work for me. I had too many side effects, and then I did Telvi, and that was back in November, and but I had other complications and stuff. But I've done 2 stem cell transplants and CAR T, and I noticed I go twice a week for platelets, and I noticed that after I did the CAR T is when I, platelets and hemoglobin was essentially why I'm going. And this has been over 2 years now that I had the CAR T. I go twice a week for transfusions, and I noticed that after CAR T. So I don't want to get, I'm 14 plus years in, and I've, you name it, I've probably been on it. And so I just, I was just wondering, I just noticed that, I've just had to have so many transfusions, and I end up getting fungal pneumonia from a contaminated platelet transfusion.
So, doctor, what other treatments, or how can she go about further treatments at this point?
Well, I mean, I think it certainly sounds, I just want to acknowledge it does sound like a challenging situation. And unfortunately, she's not alone. The issue of the low blood counts and the infections that she describes can definitely happen, especially when someone's had myeloma for that long and we start to see these cumulative side effects of treatment. Sometimes that can make it so that the folks are not eligible for clinical trials, which is what I would typically recommend. I mean, I think, in general, kind of at that stage, we probably do want to look at trials. And so I would really, if she's not already, I would really talk with her doctor, see if she's eligible for any trials, because I really think, it's once we've kind of gone through all the BCMA and the GPRC5D drugs, that's really where we need more options right now. And so I think that would be kind of, there are, of course, other things, if she hasn't had selinexor, or which could be a problem with the low platelets, though. But yeah, that would be kind of my general advice.
Thank you. Yes. And our next question coming from Elizabeth. Elizabeth is asking, what is the effect of immunotherapy on the kidneys and other organs?
So the effect of immune therapy on the kidneys and organs, well, directly, there's not really an effect. Rarely people can have immune-related side effects that can affect the kidney, like inflammation of the kidney. We've seen that with some types of immune-based therapies that have been given to people with solid tumors. So, theoretically, it could be a risk with some of the bispecific antibodies. It's not super common. Most of the time, I mean, the only real risk to the kidneys would be, if if someone had really bad cytokine release syndrome and that resulted in low blood pressure that affected the kidneys. But fortunately, that's pretty rare. So actually, we've given bispecific antibodies to folks who are on dialysis and have done so safely. So I think it's not a common concern, but definitely, there is certainly probably a theoretical risk, although in practice, I haven't seen it be a problem usually.
Well, thank you. And our next question comes from Norma. Norma's asking, is myeloma hereditary?
That's a great question, Norma. For the most part, multiple myeloma is not hereditary. However, I think it's important whenever I see a patient with multiple myeloma, I always ask sort of a baseline family history, mom, dad, brothers, sisters, grandparents. And, you do find family cohorts that or family trees where there is sort of a striking history of multiple myeloma or other plasma cell disorders. And I think in those cases that some genetic referral to genetics is probably a good idea. At our clinic, we have a hematologic malignancies genetics program that sees these patients. And I think that's often the next step I would take. It's clear that there are some families where there is a history of multiple myeloma. We're trying to understand these patients better, trying to understand what mutations might be driving this. We don't have anything quite yet like breast cancer, but we know that BRCA1 and 2 mutations confer a very high risk of developing, breast and sometimes ovarian cancer. But a lot of research is being done in this regard. So it's certainly worth investigating, worth asking about if there is a family history, seeking a genetics referral.
Thank you. And we'll take the next question from our telephone audience, please.
Thank you. Our next call is from Lawrence from Texas. Please state your question. Your line is now live.
Yes, I've been getting shots for the last 2 years. I was told I have smoldering myeloma, and what they told me after 2 years that the shots don't have the same effect, and they don't want me to take them anymore. And I also want to know how did they figure what blood test did they figure my myeloma was smoldering versus another type of myeloma?
All right. Well, without knowing what the shot is, it's a little bit hard to know how to answer the first part of the question. So I will skip that, but I can definitely answer the second question about smoldering versus myeloma. We didn't really talk about this, to be fair, but basically smoldering myeloma, you could almost think of as asymptomatic myeloma. So there's more than 10% plasma cells in the bone marrow, or the monoclonal protein is more than 3 grams per deciliter, but there's none of the Crab criteria, there's none of the slim Crab criteria, all those things we talked about earlier. And so there's no evidence that things are active. And so in general, the practice has been for most patients with smoldering multiple myeloma to observe very closely because there is certainly a risk of developing myeloma. The other thing that's worth mentioning is MGUS, which is present when the bone marrow plasma cells are less than 10% and M spike's less than 3. And again, no evidence of myeloma by the Crab criteria. And that's another condition we would generally just observe. The field has sort of been investigating treatment of high-risk smoldering multiple myeloma in clinical trials. And so I think those trials are worth looking at. But there's still quite a bit of debate as to whether high-risk smoldering or smoldering multiple myeloma should be treated. So it's best to sort of get multiple opinions about it before making a decision.
Thank you. And our next question, Larry and others are asking, what makes people ineligible for transplant at this time?
That's a great question. So transplant eligibility, what makes someone a good candidate for transplant? Well, like I mentioned earlier, at least at our center of Fred Hutch, patients need to have, we generally transplant few patients over the age of 75. And so while there is no upper age limit, I think the reality is as we get older and older, we get more and more health problems or inability to sort of do all the things that are necessary to do a transplant. That's not to say that you couldn't get a transplant if you're 77 and you're a marathon runner and you're incredibly fit and you really want to do it. I think it's certainly worth exploring. But the reality is there's very few folks out there like that. And so I think it just kind of reflects, the population. But basically what we're looking at is sort of ability to tolerate high-dose chemo. And so this high-dose chemo is tough on your body, as anyone who's undergone a transplant knows. High-dose chemotherapy, the most common side effects would be nausea, diarrhea, fatigue, risk of infections. Many patients, at least at our center, end up getting admitted for one or more of these side effects. And so, you got to have some basic good level of health, of fitness. There's some conditions that might exclude someone from transplant, like having heart failure, or being unable to sort of comply with the requirements of doing a transplant, coming into clinic every day, being within 30 minutes of the center, and having a caregiver. And so it often is sort of a complicated discussion. And certainly, if someone has been told they're transplant ineligible, I'd probably want to meet with a transplant doctor, make sure that they agree, seek an opinion from a myeloma specialist, because I think it can be sort of a complicated thing to determine.
Thank you. Yes, and Rosemary is asking, can you have CAR T-cell therapy if you've had an allogeneic or autologous stem cell transplant?
Yes, you can, of course. We would probably wait a little bit after a stem cell transplant, and it would be uncommon to need to do a CAR T therapy so soon after transplant. But yes, allogeneic transplant, which are not done as commonly for multiple myeloma anymore, but there are patients who had them maybe 10 or 5 or 10, 15 years ago who are now looking at things like CAR T therapy, and that is not an exclusion to getting a transplant. You would definitely want to meet with an immunotherapy specialist to sort of go over, the state of if you had an allo transplant, do you have chronic GVHD, other things that sort of might modify risks of side effects. But in general, it's not an exclusion factor, and neither is a prior stem cell transplant. In fact, most patients who've had a CAR T have already had a stem cell transplant.
Thank you. And we'll take the next question from our telephone audience, please.
Our next call is from Rita from Rhode Island. Please state your question. Your line is now live.
I have been on Revlimid for approximately 12 years. I'm in remission. Recently, I've been getting pulled muscles, and they last approximately 4 to 6 weeks. I've had 3 of these muscle pulled within the past 9 months. Is there any remedy for it? Do you think it is from the Revlimid, or any suggestions on what it could possibly be from?
That's a great question. I think what I'm more commonly used to, and I'm sorry to hear about this. I know how tough those can be. But, in general, with lenalidomide or Revlimid, muscle cramps are common. Getting pulled muscles, I haven't heard quite as much about. It's certainly possible it could be related to lenalidomide. I mean, I think one thing you could do, you could talk with your doctor about considering, maybe a holiday from treatment and see if that helps with how severe these pulled muscles are, or maybe reducing the dose. I think you probably want to at least explore whether there could be some relationship. There may not be, but probably want to make sure there isn't.
Thank you. And our next question is about something new for myeloma. Shai Yi is asking, is it possible to have liquid biopsies in regular blood without bone marrow biopsies by using mass spectrum for myeloma patients?
That's a great question. The question is about, the idea of using blood tests to do an MRD test. At present, to the first part of the question, we don't really have a blood test that can sort of give us all the information a bone marrow can give us. What can a bone marrow give us? Bone marrow tells us not only it helps us make a diagnosis of myeloma, but it also gives us the cytogenetic risk information that I kind of talked about a little bit earlier, the chromosomal changes. And those are important when we think about treatment and sort of risk. And so we don't really have a blood test that can give us all that. Now, that said, with respect to MRD, there are some blood tests that may come close to achieving the sensitivity that we get in the bone marrow with MRD testing. And that is still early, but I think there's a couple of assays out there that are intriguing and promising, and I certainly would hope to see that type of technology advance, because, it would be wonderful if we're checking MRD, if we had a blood test that could give us the same information as a bone marrow that could supplant the need to do all these bone marrow biopsies. So I'm hopeful that some of these tests will sort of will one day replace the need for a bone marrow, but I think at this point we don't quite have all the data yet.
Right, and it's exciting to see new advancements in the field. I am wanting to ask you what you're most excited about at this point with the progress through the years with myeloma research and myeloma treatment.
I'm really just so excited to see all these treatment options that have become available over the past really 5 years. I mean, I distinctly remember a period of time before CAR T cells were approved when we didn't, patient wasn't eligible for a study for some reason, and patients, younger patients, particularly with bad myeloma, didn't survive. And now, just 4 years later, those patients are making it. And to me, that's really powerful. I mean, I would love to be able to say that we're curing some patients, and that would be amazing. But even just to say that, that there's hope, even if some of, for example, the DARE RVD, if that doesn't work for some reason, that we have this amazing therapy, CAR T cell therapy or bispecific antibodies, that can work even when those treatments didn't. Or even to say to a patient, with Perseus, we're seeing at 4 years, such high percentage of patients still in remission, knowing that even when they relapse, there will be something like CAR T cell therapy or another combination that we can give them that will keep them going. Or even when I see patients in my clinic that have been alive with myeloma for 15 or 20 years, I'm starting to think, is there really an upper age limit, an upper time that I could say, most of the time when you see a doctor today, they might say, well, you got myeloma, average survival's, 8 to 10 years. I mean, but, is there an upper limit to that? I would like to think there isn't, right? I mean, that's really what we should be aiming for. So there is a lot that I'm really excited about, and those examples I gave are kind of I think emblematic of that.
Yes, we are very excited to hear about all of these advancements, and thank you so much, Dr. Cowan, for your continued dedication to patients and for being able to present this webcast for us today.
My pleasure.
Thank you. And for patients like Laura who called in, LLS can provide you with support and questions to follow up with your doctor on your next steps. And if we weren't able to get to your question today, please call a Leukemia and Lymphoma Society information specialist at 1-800-955-4572. Information specialists are available to speak with you from 9 a.m. to 9 p.m. Eastern Time, or you can reach out to us by emailing us at lls.org/contact us. Also, patients as well as caregivers can schedule a free personalized nutrition consultation with our dietitians at lls.org/consult. LLS offers a variety of education and support services, including online chats, like Isaac mentioned, which are free live forums that are moderated by oncology social workers. We also offer free education videos and podcasts. Please complete the evaluation for today's webcast at www.cancereducation.com/myeloma March 2024 eval. Again, cancereducation.com/myeloma March 2024 EVAL. Or complete the form in your packet and return by Tuesday, April 16th, 2024. You'll be entered to win a gift card. And please note that continuing education credit is not being offered for this program. Again, thank you, Dr. Cowan, for sharing your knowledge with us today. And we'd like to also acknowledge and thank Genentech Inc. and Biogen and Johnson & Johnson for their support of today's program. To all of the patients, caregivers, and professionals participating in today's program, on behalf of the Leukemia and Lymphoma Society, thank you for sharing your time with us. Goodbye, and we wish you well.